Let's take Jonathan, would you like to start?
Sure. Are we on?
We are. I think we're on. I think everybody is being allowed in at this point.
Welcome. Good afternoon. I'm Jonathan Kay, and welcome to the COVID-19 Virtual Research Forum, Difficult Choices in a Time of Crisis, put on by the MD-PhD program at UMass Medical School. This forum focuses on Remdesivir, currently a very scarce but potentially effective treatment for COVID-19, to discuss the ethical, social, and policy implications of resource allocation during the COVID-19 pandemic. Presentations will be given by students and expert faculty who will be present during the forum to address questions by attendees. The goal is to educate, but also to stimulate new research ideas, particularly those focused on non-bench research that might be appropriate to pursue during the time of social distancing. By way of introduction to this forum, I'd like to review the timeline of the COVID-19 pandemic. On December 31st, 2019, China reported a cluster of cases of pneumonia in people associated with the Hunan seafood wholesale market in Wuhan, Hubei province. On January 7th, 2020, Chinese health authorities confirmed the association of this cluster with the novel coronavirus SARS-CoV-2. On January 20th, 2020, there was the first confirmed case of SARS-CoV-2 infection in the United States, occurring in a 35-year-old man who had returned to Washington State from Wuhan, China, where he had visited his family. 10 days later, on January 30th, 2020, nearly 10,000 cases of this disease had been reported in 21 countries, 7 cases in the United States. By March 11, 2020, more than 118,000 cases in more than 110 countries had been reported, and the World Health Organization declared COVID-19 a pandemic. The National Institutes of Health put forward the Adaptive COVID-19 Treatment Trial, which is an adaptive platform to rapidly conduct a series of phase 3 randomized double-blind placebo-controlled trials to evaluate the clinical efficacy and safety of putative investigational therapeutic agents among hospitalized adults with laboratory-confirmed COVID-19. Dr. Finberg will discuss the ACTT-1 trial conducted at UMass Medical School as well as other sites, which evaluated treatment with Remdesivir compared to placebo. This study enrolled over 1,000 subjects between February 21 and April 19, 2020 at 45 sites in the United States, including UMass Medical Center, and at 28 sites in 9 other countries. Act 2 is now enrolling to evaluate treatment using Remdesivir as an addition to standard of care therapy, evaluating treatment with baricitinib or placebo in combination with Remdesivir and standard of care therapy. This is the publication that came out in the New England Journal of Medicine recently about the Remdesivir trial, which Dr. Finberg, one of the co-authors, will discuss. On March 13, 2020, President Trump made a proclamation on declaring a national emergency concerning the novel coronavirus disease COVID-19 outbreak. At that time, only 1,645 people, although a large number, nothing in comparison to the current number of infected individuals from 47 states had been infected with SARS-CoV-2. On May 1st, 2020, the United States Food and Drug Administration issued an emergency use authorization, or an EUA, for the unapproved product Remdesivir to treat hospitalized patients with COVID-19. As part of that emergency use authorization, 4 hospitals in Massachusetts were told that they would receive Remdesivir: Massachusetts General Hospital, Melrose Wakefield Hospital in Melrose, North Shore Medical Center in Salem, and South Coast Health System. These hospitals were given a limited number of vials, not nearly enough to treat all of the patients hospitalized at those institutions for a 5-day course, which is half the duration of the course studied in the New England Journal paper. This Remdesivir supply was pooled to be distributed by the Massachusetts Department of Public Health. As a result, UMass Memorial Medical Center received an initial shipment of 145 vials, enough medication to treat 29 patients for 5 days. At that time, there were 199 patients hospitalized at UMass Memorial Medical Center, 85 in the intensive care unit, and 28 ventilated. So this poses the question, which will be addressed in this session: who should receive emergency use remdesivir? We're going to start with a presentation by Ted Carrigan-Broda about the pharmacology of remdesivir, followed by Dr. Finberg discussing the clinical trials. This will then be followed by a presentation of 3 cases, and we will vote on several questions related to the cases. After this, Lael Gangnami and Zach Dyer will discuss some of the issues related to the distribution of a scarce resource and disparities in healthcare. We will then conclude the session with comments by others, and I turn this presentation over now to Ted Carrigan-Broda. Thanks.
Thank you very much, Dr. K. All right, I'll get us started without further ado. All right, can everyone see my presentation?
Looks good.
All right, so first introduction. I'm Ted Broda, a rising second-year MD PhD student with prior research experience in antiviral protease inhibitors. Today I will describe the intricate pharmacology of remdesivir for COVID-19 treatment, which has made news recently. A dedicated Q&A session with our expert Dr. Campion will immediately follow my presentation, so please reserve any questions for after the presentation. Thank you. So I have no financial association with Gilead Sciences, although I do admittedly appreciate their innovative antiviral drug candidates. So as you all know, SARS-CoV-2 is the cause of COVID-19. It's a beta coronavirus closely related to other virulent human viruses such as SARS-CoV and MERS-CoV. For its replication cycle, it mostly appropriates host metabolism, but still requires some virus-specific machinery. Antiviral therapies can either target the host machinery appropriated by the virus or target virus-specific targets. However, if you disrupt the host metabolism to thwart the virus, it can cause adverse effects. So ideally, you'll target the virus-specific machinery. So one part of the viral machinery essential for the life cycle is an RNA polymerase to copy the RNA genome, which is positive sense and doubles as protein synthesis instructions for the host ribosomes. So host RNA polymerases require DNA templates. However, SARS-CoV-2 lacks DNA, so it cannot use these host DNA-dependent RNA polymerases. So because SARS-CoV-2 only has RNA for its genome, it needs a viral RNA-dependent RNA polymerase. So that is a polymerase which uses an RNA template to produce an RNA copy to replicate its genome and also produce subgenomic transcripts to use as instructions for the ribosomes to produce viral proteins. So because the host has no need for RNA-dependent RNA polymerases because it only copies working RNA copies from DNA, the RDRP is a virus-specific target, which is quite useful. And so in the case of SARS-CoV-2, NSP12, which is non-structural protein 12, is the RDRP. And like host RNA polymerases, NSP12 binds nucleoside triphosphates as the substrate. Because the host produces all these NTPs to make its own RNA, NSP12 can simply steal these host NTPs to make its viral RNA. After NSP12 binds an NTP that's complementary to the next downstream base of the RNA template that it's copying, it incorporates the NTP into the growing RNA copy via a nucleophilic substitution. So keep this nucleophilic substitution idea in mind for later because it's important to the pharmacology. So just a quick refresher on nucleic acid nomenclature. You can see here, nucleobases are the bases of nucleic acid, which are typically adenine, guanine, cytosine, and uracil for RNA. If that nucleobase is bound to a sugar, it's called a nucleoside. Think S for sugar. And if that nucleoside is in turn phosphorylated, you have a nucleotide. If it's thrice phosphorylated, then it's a nucleoside triphosphate. And this nomenclature is essential for understanding the drug metabolites, which I will discuss next. So nucleotide analogs are antimetabolites that mimic endogenous nucleotide intermediates needed for RNA synthesis. A related class of drugs are nucleoside analogs, which mimic the nucleoside precursors of these natural nucleotides. So collectively, these two drug classes are nicknamed nukes. While they're structurally similar to their endogenous counterparts, these nukes feature small chemical differences that disrupt target pathways, such as viral RDRPs. And while viral RDRPs bind the same substrates as host RPs, they're low fidelity and so have a much more difficult time actually discriminating between foreign drug molecules, foreign inhibitors, and the native NTPs, while high fidelity host DNA-dependent RNA polymerases are much more resistant to the medication. So this provides viral selectivity. You can inhibit the virus RNA synthesis without hopefully disrupting the host processes. So because NSP12 binds NTPs, not just normal nucleotides, the nuke drugs need activation by stepwise phosphorylation. So you need 3 phosphates in order for these nucleotide drugs to mimic the NTPs. Fortunately, these nukes are close enough that they can just hijack the cellular pathways that already exist to turn native nucleotides and nucleosides into these NTP metabolites. And so you can think of these nukes as prodrugs of the actual active NTP metabolites, which target these enzymes. All right, finally, Remdesivir, our funky pronucleotide protagonist, rejected for Ebola, but here for redemption in a dramatic character arc. Look at that chiral phosphoramidate diester group. Those substituents are bulkier than Dwayne "The Rock" Johnson. But seriously, you have 6 stereocenters. That molecule looks more expensive than Balenciaga shoes. However, a molecule this exotic must have an explanation, so let's take a closer look at the structure. So remdesivir is a phosphoramidate pronucleotide. A pronucleotide ultimately yields an active NTP drug like simpler nukes, but it undergoes a more complex metabolism that we'll discuss later. But for now, we'll talk about the pharmacodynamics, which involves the active NTP metabolite, which is called GS443902, but for simplicity, I'll call that remdesivir triphosphate. So remdesivir triphosphate closely resembles the normal metabolite ATP, but it differs with the presence of a cyano group and a slightly changed synthetic nucleotide base, which resembles adenine. So we can see here the compounds look pretty similar, but I'll highlight the differences. We have that cyano group, which is sticking out. And we also have a different orientation of the nucleobase here. So this altered steric demand can change the function. So these 2 structural changes, while they're slight, produce an almost 800 times increase in affinity over ATP at a modeled RDRP active site. So this hasn't been empirically confirmed using the actual SARS-CoV-2 enzyme, but using similar enzymes, it's believed to, even at low doses, be able to displace the real ATP substrate. So this would be consistent with a competitive inhibitor mechanism, but that's not the only thing that this triphosphate derivative does. So NSP12 also incorporates this triphosphate derivative into the elongating RNA copy, just like a native NTP substrate. And so this mistake will actually completely stop RNA strand elongation in a process called chain termination. So rather than just being an inhibitor that slows the RNA strand elongation, it will stop it entirely. But there is a catch. SARS-CoV-2 has an unusual protein that can help it resist these chain terminator drugs. So the enzyme NSP14 has an unusual RNA proofreading exonuclease. Most viruses do not have RNA proofreading, so this is unusual and makes SARS-CoV-2 a particular challenge. This domain can remove misincorporated nucleotides, which are normally just mistakes, but can also include drugs. And this will stop elongating RNA strands. But our active metabolite is not an ordinary nuke. So there are two modes of chain terminator drugs. One is obligate and the other is delayed. The obligate chain terminators do not have a 3' hydroxynucleophile. And as I mentioned, to keep in mind with the mechanism of RNA polymerases, if there's no nucleophile, you can't do the nucleophilic substitution that you need to add nucleotides. So elongation ends there. There's nothing else you can do. But if you have NSP14 snip out that just added, then you're not going to be able to, it's not going to have any effect. So on the other hand, remdesivir triphosphate acts as a delayed chain terminator, and it has a 3' hydroxynucleophile. So the enzyme can continue to add more nucleotides at first, but after 3 additional nucleotides are added, steric hindrance from that 1' cyano group will stop elongation at the active site, and this basically has the same effect as the obligate chain terminators. However, remdesivir uniquely is resistant to these exonucleases because exonucleases can only remove nucleotides from the end of an RNA strand, as opposed to endonucleases, which can remove them from the middle. So because NSP adds those 3 nucleotides between the drug and the 3' end, it protects itself from excision. And even if the exonuclease catches the mistake in time, the orientation of that synthetic nucleobase will actually block active site alignment and prevent the exonuclease from removing it. So now let's kind of go back to our original prodrug, remdesivir. A pronucleotide, which is what class remdesivir belongs to, is the prodrug of a nucleotide analog, which in turn are precursors of the active NTP metabolites. So remdesivir is really a prodrug of a prodrug. So what benefits does a pronucleotide have over a simpler nuke? So while you think about that, I'll give you a hint. It involves rates. So the answer is pharmacokinetics. So just talked about pharmacodynamics. Now we're going to get back into pharmacokinetics here. So remdesivir has a corresponding nucleoside analog, which has the same active metabolite, but it's simpler and cheaper to make. So as we can see here, this bulky phosphoramidate diester group has to have some purpose. And so the key point here is permeability. So skip a few slides here because we're running short on time. But basically, remdesivir has that uncharged lipophilic group there that's added, which gives it good plasma membrane permeability, whereas the nucleotide and nucleoside equivalents, they either have those polar hydroxyl groups or that charged phosphate group, which prevents it from entering a cell. So remdesivir has better pharmacokinetics in this case. And then once it's inside the cell, hydrolases will rapidly metabolize it to the nucleotide, which is charged, and that actually traps it inside the cell, which is good because that's what the target is. So the active metabolites build up in the cell without building up in the plasma, and it can particularly target the viral machinery that's in the cytoplasm as well. So here's just kind of an illustration of the metabolism of remdesivir to the active metabolite, the nucleotide triphosphate. So basically, in summary, even though there's more steps to the metabolism, it's still faster metabolism than a nucleotide or nucleoside analog. So basically, all this pharmacology is cool, but does it actually translate to usefulness in the clinical setting? And so according to these preliminary results in the New England Journal of Medicine, it does appear to have a have a useful effect. And so now just kind of going over some of the clinically relevant ADME here, that you can't put it in a pill because it has complete first pass metabolism due to all those ester groups. You can't really do intramuscular injection because that's not reliable, so you have to do IV administration. But unfortunately, because remdesivir has that lipophilic phosphoramidate group, it's difficult to dissolve in water. So you need special emulsifying agents to make it It's difficult and expensive to kind of formulate. And this also adds strain to the kidneys because the emulsifying agents that are used are renally excreted. And so in the bloodstream, it's rapidly metabolized, but it accumulates intracellularly, as we already mentioned, due to that ion trapping. And its nucleoside derivative, its active metabolite here, the nucleoside triphosphate, has a really long half-life in the cell, about 40 hours. So you only have to dose it once a day in order to have a sustained effect of the drug, which is useful for IV drugs because that's inconvenient to have continuous infusion. In the plasma, it's the main metabolite, that nucleoside, is renally excreted. So does that add kidney strain? We don't really know. It also has a long half-life, so it can accumulate in the plasma. What effect does that have? Still not really known. And we also know from remdesivir trials that it tends to result in transaminitis even in healthy controls. So is there some sort of liver toxicity going on? That's definitely a question that needs to be addressed. And there's limited toxicology studies on it so far. So it does interact with some cytochrome P450s too, various transporters. What do we know about it in children and pregnant patients? So it definitely needs more studies before we can determine safety fully. And so thank you for listening to the presentation. I know it was a little bit long, but right now we're going to go into questions if we have any time. So I would like to welcome Dr. Campion, our PharmD expert, who will help address some of these questions for us.
Hi, Ted. With respect to time, we will move this Q&A section and combine it with the next Q&A we will have with the clinical trial of Remdesivir. So I'd like to next introduce Dr. Robert Finberg, who's helped to conduct some of the clinical trial research on Remdesivir here at UMass. And I want to let him share his screen to allow him to present his findings with you all. Thank you.
Okay, I'm waiting for the screen to share. Says I'm
Looks good. We can see your screen.
My screen, okay. So I'm going to talk about the trial that was done. Let me just do this. All right, can you still see it? There we go.
Yep, can still see it.
So this was the Act 1 trial for COVID-19. As was mentioned, this is an adaptive trial, which would allow it to adapt as the results became available. And this trial, as was stated before by Dr. K, enrolled people across the world. You'll notice us at the northeast point there, right below Denmark. And we actually enrolled, we were 7th in the world in terms of enrollments, right below Denmark. There were 1,063 enrollees at the trial, and it's, as was mentioned, started with the Princess Cruise Liner in February and ended on April 19th. The inclusion criteria, this was all adults because pediatric remdesivir has not been well studied. It is being now. And patients needed to have evidence of lower respiratory tract infection and a SARS-CoV-2 test within 72 hours. Exclusion criteria included people with hepatic or renal disease, allergies, or pregnant women, or people that were going to be discharged quickly. And we're going to talk more about the demographics, but this was the demographics of this worldwide trial. And you'll note that there are quite a few people here over 65, 36%, predominantly male. In terms of, this is the white versus black, African American, and Asian distribution. Again, this was a worldwide trial, and you'll notice a large percentage of Hispanic or Latino ethnic distribution. The disease is marked by comorbidities, and you'll notice here almost 50% had a history of hypertension. Obesity, type 2 diabetes were extremely common in this patient trial. The main primary endpoint was time to recovery. And the day of recovery is defined as the first day in which the patient satisfies one of the following three categories from this ordinal scale. hospitalized not requiring oxygen, not hospitalized but limited, or not hospitalized with no activities. The secondary endpoints were mortality at 14 days or mortality at 28 days, and that has not been reported because we are actually still collecting the data. This was an adaptive trial, as is noted here. The second trial, which is called Act 2, has already started. And in that trial, we're using remdesivir plus or minus baricitinib, which is a JAK kinase inhibitor and immunomodulator. However, in terms of Act 1, that trial ended on the 19th. And at the time, at the investigators meeting, the investigators were told that the Data Safety Monitoring Board had something they wanted to talk to us about. And it turned out that what the monitoring board found was that, in fact, an endpoint was reached. The primary endpoint, there was a statistically significant difference between time to recovery in the remdesivir group versus the placebo group. The secondary endpoint, which was mortality, was trending towards significance, but of course we don't even have that final data yet. That's still being incorporated. So on this basis, because of the difference in recovery, the FDA took a rather unusual decision. Before the trial was even published, the results were made public, and last week, the preliminary results came out in the New England Journal. And what they indicated was that recovery was 31% faster, 11 days versus 15 days, for severe disease in the remdesivir group, and there was a difference in mortality. And this just shows overall a percentage of those who recovered. You'll note that the remdesivir group in the blue is essentially ahead, starting at a week post infusion against the placebo group in the overall analysis, which was 1,063 patients. If you look at subgroup analysis, what you see down here is that the patients who were hospitalized and not receiving oxygen did much better in terms of recovery rate with remdesivir, as did patients receiving oxygen. There was not any favorable effect of remdesivir among those who were randomized at the time that they were receiving mechanical ventilation or extracorporeal membrane oxygenation. This just shows stratification by disease. And again, the major points where remdesivir seemed to be better was in patients receiving oxygen. Patients receiving mechanical ventilation, there was really no advantage at all in remdesivir. And those receiving high flow oxygen or non-invasive mechanical ventilation had an intermediate finding. So the results conclusion, a 10-day course of remdesivir was superior to placebo in hospitalized patients. There was a benefit in recovery. There's a benefit at day 15. It was most apparent in those receiving oxygen, but not mechanically ventilated. As I noted, the trial data is still ongoing. Actually, we're still submitting data to the final data analysis. There was another trial that came out, Wong et al. In the Lancet, which demonstrated a trend toward a faster clinical improvement, but did not show a statistically significant analysis. This trial differed in a variety of ways, including the use of other drugs and steroids, and had not achieved its target enrollment. And I guess that concludes my presentation.
Thank you very much, Bob. Question about the improvement. The patients who were receiving oxygen seemed to do better in this trial than the patients who didn't. Patients who received oxygen were at step 5 on that ordinal scale and were further away from the improvement benchmark than were the patients who were hospitalized not receiving oxygen, who were at step 4. Why might patients requiring oxygen do better with an antiviral than patients who might have less severe disease?
Well, most, I mean, it's hard to answer that question without more data, but most patients with this disease recover spontaneously. Obviously, those who this is limited to hospitalized patients, usually with comorbid conditions, and we don't really have the things that you would like to have, like the viral loads, but those will be forthcoming, and I think we'll learn a little bit more. One might hypothesize that only those with high viral loads actually benefit from the drug. That's one possible hypothesis.
Very interesting. There's a question about the pharmacology for TED. What kind of toxicology studies would be useful to understand the renal and liver toxicity of remdesivir? Would it be studies in non-human primates? Would these have already been done in phase 1 trials? And what kinds of specialized studies would be important?
So I'm honestly not entirely sure what the best way to go about these toxicology studies would be. I do know that during the Ebola trial, they actually did administer remdesivir to some people who had hepatic impairments, and they seemed to do okay on it. So maybe during these trials, as they progress, because there's multiple phase 3 trials going on, they could slowly adapt the different requirements to maybe include people with certain kidney or hepatic impairments, and try to see if there's any adverse effects, and then end that kind of experimental trial if there's any issues. But maybe Dr. Campion could add something to that.
So one thing I would say, there were fewer serious adverse events actually in the remdesivir group than the placebo group, which is certainly a good thing. But there'll be after marketing analyses. And Maureen, what would you say about toxicity?
Yeah, I would say the same thing. I think we're going to have to look at after-market analyses in terms of particularly the hepatic adverse events. As Ted mentioned, in the Ebola trials, there were grade 1 and grade 2 adverse events, but there were no grade 3 or grade 4 adverse events associated with remdesivir that led to it being stopped or halting therapy. And so I think that going forward, once we establish this as what its role is within the treatment of COVID-19, then we'll have to evaluate in patients who have hepatic or renal impairment, safe to give it, and if a dose adjustment is required.
There's another question about, is there a plan to treat patients with remdesivir who do not need hospitalization? The comments made that early treatment might prevent hospitalization.
Yeah, that's a really complex issue. I think we're looking for other drugs. Again, this was a 10-day infusion. Now, people that got better fast obviously stopped, but we don't really know the answer to that question. And most patients who don't have comorbid conditions at this point are actually discharged home. Now, that isn't what they do in China or Japan, but it is what we do. And of course, most of them do well. It would be nice to have another drug that we could use that wasn't IV, and I think we would use it, but we're not quite there yet. I do think, these double-blind trials show something about what you can learn, and it is, I think, a triumph for particularly American medicine that we were able to at least get something done.
And it's amazing how quickly that trial was conducted and the positive results that were seen in the setting of this pandemic. There's a question about, does dialysis remove the drug or emulsifiers?
Maureen, you want to talk about that? I mean, this is being, we don't give it to dialyzed patients at the moment, but go ahead.
We are not giving it to dialyzed patients at the moment for a couple reasons. So the cyclodextrin can be removed by CVVH filters, but there are concerns right now of just the clotting in COVID patients and their risk for clotting, as well as their treatment on CVVH. And so we have prevented its use currently, but as we said, post-marketing studies will really show if there is safety for that going forward. The cyclodextrin can be removed, but there's other challenges in treating these COVID patients.
And one of the challenges are comorbidities. And someone asked, is there, if controlled hypertension or controlled diabetes, is as much of a risk as uncontrolled hypertension or uncontrolled diabetes?
I don't have an answer for that. I think we need to look closer at the data to get to that.
And then Zach Dyer, who's going to talk in a bit, said that it looks as if the results were not separately statistically significant for ethno-racial subgroups besides white participants. Any thoughts as to why this might be? I assume that the study was not powered to look at statistical significance among ethnic subgroups.
That's correct. And again, this is an international study. It was a huge number of patients, but it's hard to look without big numbers. There will be subgroup analysis, but I'm not sure that we'll be able to get statistics on all subgroups.
So congratulations on being the 7th highest enroller in this international study, and such a great study. It's a real tribute to the medical school and to your efforts, so thank you very much.
All the people that did the work, and it takes a huge team to do this, and the research nurses do most of it as usual in healthcare.
Fantastic. Well, with those data, we'll move on to some case presentations and questions about which of these patients might be treated with remdesivir. So Jeff Zhao and Kevin Gao are going to give the case presentations, as well as Rafaela Umaten.
Thank you, Dr. K. Now that we've learned about remdesivir's mechanism of action and its efficacy in clinical trials, the next step is to bring this medicine to the clinic. So we have a total of 3 case presentations. These are patients of Dr. Finberg and Dr. Ianetti. As Dr. K introduced in the very beginning, UMass received enough emergency use authorization remdesivir to treat 29 patients. For the following presentations, we'd like to you to imagine yourself as the UMass infectious disease team. As we go through each patient, consider whether you would give each patient one of the limited remdesivir doses. At the end of all 3 cases, we have a poll to sort of capture your thoughts. So our first patient is Mr. PB, who is a factory supervisor with obesity, hypertension, hyperlipidemia, and prediabetes. His story begins in the middle of April when he attended a barbecue party with a friend who later tested positive. The following week, he developed flu-like symptoms. His wife called their primary care office, who advised both of them to self-quarantine. The very next day, they tested positive for COVID-19, and again, they were advised to self-quarantine. Now, the wife actually had much milder symptoms than our patient, Mr. PB, and she actually gradually recovered over the next week. However, our patient's illness persisted and continued to get worse. So the patient's wife was actually extremely proactive, and she actually called their primary care office every 2 or 3 days looking for advice. And it was not until finally the 4th of May that they were advised to go to the emergency room. So at this point, Mr. PB has already been positive for COVID-19 for 7 days and has been symptomatic for 11 days. In the emergency room, Mr. PB's vitals were significant for a rapid respiratory rate and poor oxygen saturation. He very rapidly needed high flow oxygen to maintain his saturations. And on physical exam, he was in acute distress, ill appearing. There were rales in all lung quadrants and diminished breath sounds. His ED labs were significant for leukocytosis and minor metabolic abnormalities, and his chest x-ray revealed multifocal pneumonia. He was given ceftriaxone, azithromycin, and admitted to the ICU. Mr. PB's medical history is fairly straightforward. The main risk factor, again, is obesity and many of the other comorbidities. He is a former smoker and drinks alcohol socially. His wife is heavily involved in his medical care, and in the record, there are actually many communications from her. In the ICU, he was placed on non-invasive mechanical ventilation through CPAP. He received convalescent plasma 3 times, and his hospital course was complicated by bilateral DVTs and an acute flare of left ankle gout. So by the 12th, there has actually been minimal improvement in his disease. He is still requiring high levels of oxygen. So on May 12th, this was actually the date that the critical care team consulted infectious disease. And they really had one question. So there is EUA remdesivir at UMass, and can we give this patient remdesivir? So we're gonna stop the first patient case right here, but don't forget it, we have a poll later, and we'll move on to Kevin presenting the second case.
Thanks, Jeff. So here's our second patient. This is a Mr. WV. He's a 67-year-old male smoker. He has a past medical history of type 2 diabetes and hypertension, as well as GERD and dysphagia. Importantly, he has a significant psychiatric history of schizophrenia, dementia, and disruptive mood disorder. And he presents to the ED from a skilled nursing facility where he's been for the past 5 years with a 4-day history of fever, lethargy, cough, shortness of breath, and an altered mental status. At the ED, his vitals are significant for a fever, low blood pressure, and saturating on oxygen at 93% on 4 liters of oxygen by nasal cannula. On physical exam, he appears thin and pale. On respiratory exam, you note that he has mild rales at his right lower lobe and diminished breath sounds at his base. And on neurologic exam, he's lethargic and oriented to only person in place. So his labs were tested positive for COVID-19 by nasal swab. He was found to be hypoglycemic with a low blood glucose, and he had a BUN of 37, a lactate of 3.1, and AGFR of 42. So he's having a metabolic disturbance and lactic acidosis. His peripheral blood, when manually differentiated, show a decrease in lymphocytes and an elevated neutrophil count. And on imaging in the ED, he had a chest X-ray which showed multifocal pneumonia with bilateral infiltrates at his right middle lobe, retrocardiac area, and left lower lobe. And this is what the chest X-ray showed. You can see that there's some some opacity over here where it was described. So the patient was found to be in critical condition. He was in acute hypoxic respiratory failure. He has sepsis. He qualified for sepsis. He had several different sources of bacteria. His urinalysis showed positive for Enterococcus. His sputum was positive for strep pneumo, ESBL Klebsiella, and MRSA, although he did not seem to have bacteremia. He also developed demand ischemia as a result of this sepsis, and he was hemodynamically unstable, leading to acute kidney injury and metabolic encephalopathy as a result of his acute kidney injury. He was immediately treated and stabilized. He was intubated and given mechanical ventilation, and he was started on empiric antibiotic treatment with piptazo and vancomycin, given dextrose to correct his hypoglycemia, and IV fluid boluses to correct his hemodynamic instability. So, would you give this patient remdesivir? And I'll transition over to Dr. Umatan.
Okay. Good evening. Can you see the PowerPoint?
We can see the PowerPoint. Looks great.
Now?
Yes, yes.
Thank you. Thank you for giving us the opportunity to discuss about this patient. Rafaela Yumetan, I'm a current neuroimmunology fellow, and I work together with Dr. Carolina Ionetti, the director of the Multiple Sclerosis Center at UMass. We would like to discuss one patient that was recently admitted, patient 64, African-American, with a history of an aggressive form of progressive multiple sclerosis on B-cell therapy, ocrelizumab, and bilateral spastic paraparesis. As you can see, his past medical history is very long. Is most remarkably, he had end-stage renal disease on hemodialysis, a nephrectomy in 1999. He has high blood pressure, high cholesterol, diabetes on insulin, AFib not on any anticoagulation, chronic pain on opioids, and possible seizure disorder. He has been in disability for many years, former smoker, and a history of alcohol abuse in remission. His medication includes some aspirin, ferrous sulfate for chronic microcytic anemia, blood pressure medication, insulin, hydrocodone acetaminophen, and ocrelizumab, one infusion every 6 months. And the last infusion was September 2019. With regards to his multiple sclerosis history, he has this aggressive form of multiple sclerosis, diagnosis 1985. He tried over the years a series of medication of disease-modifying therapies, and most recently, during the past 9 years, on B-cell therapy, rituximab and ocrelizumab. His last follow-up with us was in April, just before his hospitalization, and at that time it was clinically stable with a disability score EDSS of 6.5 for the use of a walker. His MRI showed a moderate burden of disease with periventricular and subcortical lesion, spinal cord lesion of the cervical and thoracic spine. And overall, the presence of spinal cord lesions and being African American definitely correlate, generally speaking, to an increased risk of disability and severity of disease. In February, he was involved in a motor vehicle accident, possibly related to a seizure, several fractures, and a tongue biting. In the ED, all the workup came back negative for seizures, and discharge on an antiepileptic for prevention, but then discontinued. And later on March, he had a generalized tonic-clonic seizure witnessed while in dialysis session. In ED, he was somnolent with urinary incontinence. His blood work and vital signs were not very far from his baseline. SARS-CoV-2 PCR was negative at that time, and it was found to have a UTI, a urinary tract infection, that we know decreased the seizure threshold. He was discharged on an anti-seizure medication, levetiracetam, and EEG done as an outpatient was not concerning for epileptiform discharges. Then coming to the most recent hospitalization, on April 10th, he came to the emergency department for an acute onset of fever, 100.7, as well as altered mental status while receiving dialysis. His saturation of oxygen was 93% in room air, but he was tachycardic and tachypneic. White blood count was 4.3 with an absolute lymphocytes count of 0.4. His comprehensive metabolic panel was not, again, very far from his baseline with a creatinine of 3.4 and eGFR of 21, lactic acid 1.7, and CRP of 50.1. SARS-CoV-2 PCR was positive. Chest X-ray showed multifocal pneumonia with bilateral infiltrates. A DAC panel was done, it was negative. Because it was saturating 93% in room air, he just needed 2 liters or so of nasal cannula oxygen, and he was placed in CDU for monitoring. 12 days after his admission, while in the hospital, he became severely encephalopathic, requiring sedation and restraints. Again, he was still feverish. His labs were not much concerning, but neurology was consulted for the cause of encephalopathy, which was felt to be most likely toxic metabolic in the setting of infection and less likely related to a subclinical seizure. And then 2 days after, a rapid response was activated for acute drop of saturation. He was transferred to ICU, intubated, found to be in septic shock, requiring pressure. Hemodialysis was stopped, placed on CCVH, and repeated SARS-CoV-2 PCR resulted positive again. The chest X-ray did not show worsening of his infiltrates. Because he was on a B-cell therapy, immunoglobulin levels were checked, and indeed his IgG level was mildly low, and most likely related to the acquired immunodeficiency in the setting of his treatment for MS, and neurology recommended some IVIG for 3 doses to reverse the acquired immunodeficiency. Subsequently, he also had a spontaneous SOS muscle bleed and received a blood transfusion for 4 days with some improvement. Should this patient receive Remdesivir? I think we can hold on this.
Dr. Gumenton, if you could unshare your screen really quickly.
Yes.
Thank you.
You're welcome.
All right. So in the meantime, so our question again is, now that you've heard from each of the 3 cases, here is a poll. Recall, we only have 29 courses of Remdesivir in the UMass system. Which of these patients, if any, do you believe should receive Remdesivir? On the right side, we have really quick summaries, but in the meantime, while we get the poll up right now, if you have any questions about any of these patients, please enter them into the Zoom chat. and we'll be able to answer them while the poll is up. Oh, sorry, is my screen not up?
No, it's not.
Oh, okay. That's unfortunate. Give me a second. I apologize.
Go over the 3 patients. So the Jeff, your patient.
Yep. So our first patient is a 53-year-old man with obesity and a greater than 15-day history of COVID-19 respiratory failure, requiring non-invasive mechanical ventilation.
My patient was a 67-year-old male, white male, from a long-term nursing facility with type 2 diabetes, schizophrenia, and multiple psychiatric comorbidity. He was hospitalized for COVID-19 and had also sepsis, AKI encephalopathy, and bacterial pneumonia requiring invasive mechanical ventilation.
And my patient was a 64 African-American man on disability with an aggressive form of multiple sclerosis, type 2 diabetes on insulin, and stage renal disease on hemodialysis, and history of seizures, hospitalized for COVID-19 pneumonia and encephalopathy, and later septic shock requiring pressor, CCVH, and invasive mechanical ventilation.
So now we've launched the polling. Everyone should see that they can pick which patients they believe should receive the remdesivir. You can pick more than one patient, and we will share the results after the polling is done.
In the meantime, if you have any questions, feel free to type them into the chat.
There's a question about how do we vote in polling. There should be a screen that's appearing where you choose one of the 4 answers.
You may have to go to reactions to pull up the screen.
No, on the bottom area where you've got mute video, there is an icon that says polls. You click on that, and that's where the polling comes up with patient ABC and none of the patients. You then vote by clicking to the right on the selection of your choice.
I think it looks different on different screens. On my screen, on the bottom ribbon, on the pretty far to the right, it says reactions. I get the poll.
Okay, it looks like we had some results, although, well, we'll just share this set. It's pretty representative of the other poll. In total, we seem to have around 60 responses, and it seems that the consensus answer is that patient A should receive the remdesivir. So let's discuss.
So moving on to what was actually done in the clinic, patient A did not receive remdesivir, patient B did receive remdesivir, and patient C did not. We'll briefly go into the reasons about why or why not the clinical team made these decisions. So at UMass, there are actually internal guidelines to advise clinicians about which patients should receive emergency use authorization remdesivir. These guidelines were agreed upon through discussion with infectious disease, critical care, triage, crisis of care committees. These guidelines are specific to UMass, although many hospitals across Massachusetts have similar, albeit slightly different guidelines. So at UMass, our eligibility criteria for receiving EUA remdesivir is greater than 6 liters of oxygen, or non-invasive or invasive mechanical ventilation, a positive coronavirus test, and confirmed COVID for less than 10 days. The exclusion criteria are poor kidney or renal function by low eGFR, elevated liver enzymes indicating liver damage, or if the patient was enrolled in another remdesivir trial, or if the attending felt that the patient had poor prognosis. Pregnant women and pediatric patients are specialized populations that may be considered upon provider request, although there is limited data from the research trials. So why did each of these patients receive remdesivir or not? So the first patient was actually excluded from receiving EUA remdesivir because his symptoms, he had greater than 10 days since his COVID-19 test was positive. In his case, he actually improved without further complications without receiving remdesivir and was discharged to home.
So in the case of patient B, his Hemodynamic instability was corrected, and that led to an improvement in his renal function, which allowed him to receive remdesivir without worry of significant renal toxicity. However, he was excluded from clinical trials of remdesivir and only given remdesivir by emergency use authorization because of his psychiatric comorbidities, which were not parts of the clinical trial cohorts. He improved without further complications and was discharged to a nursing facility 23 days after hospitalization.
And the patient number 3, he did not receive remdesivir for his poor renal function, being on end-stage renal disease and hemodialysis. On day 30 of his hospitalization, he got 1 dose of convalescent plasma, and because he remained pretty much encephalopathic, at a certain point he got a tracheostomy and a PEC tube, and finally discharged on day 45 on a long-term facility.
So in summary, we've presented 3 patient cases illustrating the use of emergency use authorization remdesivir. And given the data from the remdesivir trials, our hospital and others have assembled recommendations and guidelines about the administration of remdesivir in practice. However, compared to what is commonly seen in clinical trials, real patient populations are complicated, as shown by patients B and C. These policy guidelines have been established based on scientific evidence with consideration to safety to patients. However, it's also important to consider how our policies impact the communities and patients that we serve. Coming up next after this presentation, Zach and Lael will speak substantially about minorities and also socioeconomic groups that are disproportionately affected by COVID-19, both in frequency and severity of disease. When we consider the policies that we create in our hospitals in clinical practice, are disadvantaged groups disproportionately affected by any of these policies? This is mostly just food for thought, and we'll end right here to thank you, everyone.
Great, thanks, Jeff. I'd like to take this opportunity to acknowledge Michael Collins and Eric Dixon, who are attending this virtual research forum, for their leadership of the medical school and the healthcare system during this very difficult time. They just sent out a joint email about the situation that we face with the tragic death of George Floyd in Minneapolis, and they have exhibited great commitment and leadership to the inclusive culture at the medical school and at UMass Memorial Healthcare, and to addressing racial disparities in healthcare. And that's a perfect introduction to the next presentation by Zach Dyer about why the disproportionate effect of COVID-19 on minority populations. Zach?
Great, thank you. Share my screen here. So yeah, thank you for that introduction. With everything that's going on in the world, and especially today with what's going on in the country, it's important to consider how the places we live, work, and learn, the communities, the policies that our society is built around benefit some groups over others. The conversations we have about health disparities and health inequities, differences in mortality rates, differences in morbidity and experiences with the healthcare system, they're not just academic inquiries. And I think it's important for us to remember that the reality of the lives of far too many people in this country, far too many of our patients, and many members of our own UMass community are steeped in these disparities. With that, I'm going to talk about a very narrow set of these disparities and how they may be influencing the case and fatality rates among Black and Latino communities in the US. So we'll start with sort of where this conversation started, which was in New York City, where they were one of the first to publish case rate disparities, publish the case rates by ethno-racial group. And it was clear then, and it wasn't particularly surprising to those of us in public health to see that there were clear and staggering disparities between different ethno-racial groups. that it was not just case rates, but also hospitalization rates and also mortality rates due to COVID-19 in different geographies around the country. There's a lot on this slide, but it's just to say that this shows the difference between the percentage of population and the percentage of infections of different states who are reporting this information around the country. And you can see that the blue bar represents how wide of a gap that is between the percent of the population that's Black and the percent of the infections among the Black population. And you can see that depending on where you are, it's fairly wide. And you know, one of the ones that stuck out to me is that if you look at the District of Columbia, the difference between the percent of population, percent of infections was relatively small, 44 versus 46%. But if you look at the difference in population versus deaths, that's 44 versus 75% is one of the largest disparities you saw there. We're not seeing as much of this in Massachusetts, but Massachusetts also has not terrific data on ethno-racial groups for our healthcare systems, or for statewide data, rather. I was curious because Massachusetts, what they are doing is putting out information by city and town to take a look at if we know the rates that are, the case rates that are happening in every Massachusetts municipality, all 351 of them, and we know the census demographics of those communities, how they compare, how that maps together. And unsurprisingly, on average, though there are exceptions, as you increase in the percentage of the population that is a population of color, the COVID-19 case rate increases on average, all the way out to the highest data point there is Chelsea, Mass. So when I'm thinking about the domains of disparities in the COVID-19 pandemic, I'm generally thinking about three things. So exposure, comorbidities, and what we call weathering, and disparities in healthcare. So first, exposure. I think a lot about occupational exposures. So Black and Latino workers are more likely to work frontline jobs than white workers. Members of ethno-racial groups, ethno-racial minority groups are less likely to have paid sick leave protections. And then among specific industries like agriculture or even licensed nurses, you see a disproportionate representation by ethno-racial minority groups. And these two graphs are just showing for the US and for Massachusetts, the sort of total percent of the worker population, which is the dashed line, versus how they're represented in these different frontline industries. And in general, you'll see that white workers are underrepresented in frontline industries, and Black and Latino workers are overrepresented in general. And this is also shown looking specifically at Chelsea, which is one of the worst hit communities in the state and actually in the country, that the percent of the population that are frontline workers and the percent of the population that are Hispanic, Latinx they map together almost perfectly. That there's, in much of Chelsea, the percent of the workers who are in COVID-19 essential positions is usually around 60% or higher, all the way up to 80%, close to 90% in some of those census tracts. Another area of disproportionate exposure is in transportation. And this is just looking at Worcester, Massachusetts, and the US, and they all follow very similar trends. But Black and Latino residents of the US, Worcester, and Massachusetts all disproportionately use public transit or carpool, whereas white workers disproportionately drive alone. And yeah, across the country, individuals from ethno-racial minority groups actually make up 2/3 of public transit users, and public transit is obviously one place where it's very difficult to socially distance. And then another area is ability to isolate. So if someone is at home, if someone is tests positive for COVID, are they actually able to isolate within their home? And this is just looking at the percent of households that have greater than one occupant per bedroom, which makes it a lot harder to isolate, and the difference between the white, Latino, and Black population in Massachusetts and Worcester. Some other disparities in exposure that we think about members of ethno-racial minority groups are more likely to live in densely populated areas, particularly in the north. They're more likely to live in multi-generational homes. There could be 2, 3, 4 generations living together. More likely to have to travel farther to access grocery stores and medical facilities. And if they're using public transit or really any other mode of transportation, they're going to have more opportunities to come in contact with people. And then also overrepresentation in jails, prisons, and detention centers, which we know are very hard hit in the pandemic. Then comorbidities in healthcare, the other 2 domains that we think about, and I think particularly when we're talking about clinical trials, which Lael is going to talk about next. This is something to consider as well. There are clear disparities in diabetes, both in the chart showing emergency department visit rates in Massachusetts, where Black and Hispanic Latino communities are visiting the emergency department at significantly higher rates than white populations, that Black and Hispanic residents report being diagnosed with diabetes at a higher rate, and Black Massachusetts residents are twice as likely to die from diabetes complications compared to white Massachusetts residents. We also see similar trends in cardiovascular health, whether it's stroke or MI or congestive heart failure or hypertension. This is all, again, looking at hospitalizations in Massachusetts, but Black adults are 5 times more likely to be hospitalized for hypertension compared to white adults in Massachusetts. And then disparities in chronic lower respiratory disease. This is mostly seen with asthma and much more seen in children than in older adults, but asthma hospitalization rates for Black children and Hispanic children are 3.6 and 2.6 times higher than the rate for white non-Hispanic children. As you get into older generations, it isn't seen as much, likely due to differences in tobacco smoking trends. And then one that is, I think, particularly important when we're talking about clinical trials and remdesivir in particular is disparities in kidney disease. And this is something that's been documented for a long time and thought out as to all the socioeconomic reasons why this may be. But Black residents have 4 times the risk, Native American residents have 2 times the risk, Latino residents have 2 times the risk, and Asian residents have 1.6 times the risk of developing end-stage renal disease compared to white residents. And this is across the entire US. This is not Massachusetts-specific data. And then in access to healthcare, there's the long persisting difference in insurance rates. And I was saying earlier that there's much denser populations. Black and Latino residents are likely to live in denser areas in the north, but in the south, they're much more likely to live in states where there was no expansion of Medicaid, where states opted not to expand Medicaid, which would have benefited those populations. So we're still seeing, even to this day, more than twice the rate of uninsurance among Hispanic Latino populations compared to the white population. We see similar things with delaying care in the past year, and this is going to be, I saw a study today that said 50% of respondents to a national survey showed that they're at least themselves or another adult in their family delayed care during the COVID pandemic. And this is what it looked like before the COVID pandemic, that Black and Hispanic Latino individuals were more likely to delay seeking care. They're less likely to have a usual source of care and are more likely to experience discrimination while seeking care. And there's all the reasons to expect that that may be exaggerated in the current pandemic. And thinking specifically about the pandemic and how some of these existing disparities may reinforce in healthcare, this is the scoring criteria that was used for the guidance in Massachusetts in the case that there had to be healthcare rationing, particularly for ventilators, ICU beds. And a lot of it depends on the existing comorbid conditions that people have. Some of it, the SOFA score is more objective, but for people, since we know that there are more comorbid conditions disproportionately in the Black community, they're naturally going to score higher there. And then the more subjective, saving the most life years is likely to also see a similar impact. And then some of the things that are outside of cases and deaths, so that is what we are most thinking about, but there's people of color are less likely to receive a stimulus or unemployment bonus. Job security in the future is less likely for those who will be most impacted by COVID-19. Learning loss is more detrimental and harder to recover for low-income and ESL students. Small business owners of color are less likely to navigate the payment protection program loan requirements. And then there's, particularly in Massachusetts for this week and last week, the post-closure surge in healthcare. Talked about the delays in healthcare, but that surge may have more detrimental effects on people who are sicker. And now there's a very quick overview of different areas of disparities in the COVID pandemic in the US and Massachusetts, but Lael is going to talk more specifically about clinical trials. But I think I'm not sure if we have time for questions or not at this point, or if we'll save them until after Lael's.
We'll have questions after Lael's presentation. Thanks very much, Zach, for that excellent presentation. Lael Gangmeni, second-year medical student in the MD PhD program, is going to talk now about racial disparities in clinical trials. Why is this relevant to COVID-19? Lael, thanks.
Okay, can you all hear me?
Yes.
Okay, cool. Thank you so much, Zach. That was wonderful. As Dr. K just said, I'm a second year, or rising second year, completion research branch of the MD PhD program. So you just heard from Zach about how comorbidities, determinants of health, and geographic differences interact to form patterns that of COVID-19 prevalence and impact. And so I want you to keep this in mind as we'll be coming back to it later on in my presentation. I'm going to give you a historical context of racial and ethnic underrepresentation research and around racial disparities in clinical trials. So unfortunately, racial and ethnic minorities experience preventable diseases and poor health outcomes, yet they are not included in research studies as often as white people. For too long, researchers assumed that what they learned about white men could safely be applied to anyone, and we now know that's not true. For example, clopidogrel, an antiplatelet drug, is no better than a placebo for 75% of Pacific Islanders who take it. The most common asthma controlling medications approved by the FDA, based on how they performed in studies that included mostly white people, were later shown to often not work as well in Puerto Ricans and African Americans who have the highest rate and greatest severity of asthma. Carbamazepine, a drug used to treat seizures and nerve pain, is more likely to cause Stevens-Johnson syndrome in Asians than in other racial groups. And finally, as Dr. K brought to my attention on Monday, according to the EMBRACE study, belimumab, a drug for the treatment of systemic lupus erythematosus, was found to be less effective in Black subjects. And this is significant because Black patients have more severe SLE and more frequent lupus nephritis than other racial groups. Nonetheless, the efficacy and safety of intravenous belimumab was originally demonstrated in 3 phase 3 SLE studies, where few Black patients were included, and this limited the subgroup analyses. Despite the growing evidence that race and ethnicity play an important role in the risk for many diseases and responses to environmental exposures, minorities are still vastly underrepresented in clinical trials. And here's just a brief disclaimer before we continue. This presentation is not exhaustive since race is complex and ever evolving. Furthermore, race is often represented in a Black-white binary, which is limited and not ideal. A lot of research does this, so although many of the examples I'll give can fall into binaries, please try to keep in mind the multiple intersections of race, health, and identity. Another thing I want you to think on: the easiest reaction to a study finding a health difference between people of different ethnicities might be to think that the difference is due to something biological related to race. Sometimes there is a genetic component, but the health disparities experienced by minority populations can have many other causes. People of different races and ethnicities often grew up in different cultural environments with diverse diets and health practices. Economic opportunity is not evenly distributed among all races, and different populations have unique histories that contribute to health differences today. We can't work to reduce these disparities if we don't understand the mechanisms underlying them. To do that, our scientific research must include those groups that have historically been excluded or underrepresented. Let's start with an example of racial disparities in clinical trials. In 2015, the FDA approved Ninlaro for the treatment of multiple myeloma after positive outcomes from a clinical trial. The drug can be taken as a pill, sparing patients painful injections or cumbersome IV treatments. The trial, however, had a very poor racial composition. 1 out of 5 people diagnosed with multiple myeloma in the US is Black, and African Americans are more than twice as likely as white Americans to be diagnosed with a blood cancer. Yet of the 722 participants in the trial, only 13 or 1.8% were Black. As a result, desperately ill Black patients who have exhausted other treatment options aren't getting early access to experimental drugs that could extend their lifespans or improve their quality of life. The racial disparity in the Ninlaro study isn't unusual, reflecting the reluctance of the FDA to force drug makers to enroll more minority patients and the failure of most manufacturers to do so voluntarily. Stark underrepresentation of African Americans and American Indians is widespread in clinical trials for cancer drugs, even when the type of cancer disproportionately affects them. ProPublica found that in trials for 24 of the 31 cancer drugs approved in 2015, fewer than 5% of the patients were Black. You can see on the right that regardless of which racial group has a higher incidence of a certain disease, white people are generally overrepresented in clinical trials. There are many such examples. In fact, in 230 trials leading to FDA cancer drug approvals over the past decade, race was reported in only 63% of the trials. Black people represented only 3.1% of total trial participants, and Hispanics represented 6.1%. Both Black people and Hispanics were underrepresented in trials, with Black enrollees representing only 22% of their expected cancer incidence, and Hispanic enrollees representing 44% of expected incidence. By contrast, white people were enrolled at 98% their rate of cancer incidence, and Asians at 438% their expected cancer incidence rate. Therefore, suboptimal race reporting and representation, especially in Black and Hispanic people, occurs regularly in landmark clinical trials. Yet without adequate representation in such trials, meaningful subset analysis is made impossible. So increased efforts are needed to enhance minority representation and to eliminate these disparities. Several factors contribute to barriers to inclusivity during study recruitment. One of them is mistrust of the scientific community or the healthcare system on the part of racial and ethnic minorities. This is often founded on previous personal, historical, or cultural negative experiences. Another is communication challenges. This includes things like low English proficiency and low health literacy, thus hindering people in finding out when studies are happening that may benefit them and whether or not they are eligible. There are also some cultural stigmas and potential clashes of beliefs around healthcare that could hinder the process. Economic and time constraints, like having to work at times when the study runs, could narrow down the potential pool of participants. In terms of mobility, neighborhood and transportation options could be complicated. As Zach told us, racial minorities are more likely to rely exclusively on public transportation. As for lack of opportunity, study exclusion criteria may disproportionately exclude certain populations. Furthermore, clinicians and researchers burdened with costs of data collection may also be less likely to recruit such participants. Not only do these make inclusive recruitment complicated, but as Zach so thoroughly demonstrated in his presentation, most of these factors also interact to contribute to the higher prevalence and worse outcomes from COVID-19 in racial and ethnic minorities. There are many potential benefits to inclusivity. Underserved populations would have improved access to novel therapies. Pivotal trials would be more representative of the US population. The additional data would provide further understanding of the biology of diseases with higher incidence in specific populations. This would help in the identification of molecular subtypes that could be targeted by established or novel drugs. As the image on the right demonstrates, there is a feedback loop that includes determinants of health, health outcomes, clinical trials and research, and interventions. If positive change were made in research, the cyclical nature of it all would yield great benefits all around. In terms of COVID-19, Zach showed us that current data suggests a disproportionate burden of illness and death among racial and ethnic minority groups. In New York City, for example, death rates among Black people and Latinos are substantially higher, about 2 times that of white people or Asians. There are many reasons for such disparities, which studies have yet to fully uncover. Hopefully they're conducted in such a way that these often underrepresented groups are well accounted for. On the left, you can see the demographic information from the preliminary report of Remdesivir for the treatment of COVID-19, released on May 22nd, 2020. As Dr. Finberg explained, the report was on a total of 1,063 patients in 60 trial sites and 13 subsites. There were many nations represented in this study, including the United Nations, the US, Denmark, the United Kingdom, Greece, Korea, Mexico, Spain, Japan, and Singapore. No African nation is included, and only one Latin American one is. I say this to highlight the fact that racial categories are very broad and sweep people from all over the world into few categories. So even though the Black and Latinx populations included in this study are larger than in the average study, many subgroups within these populations are likely left out. For example, although 20.6% of subjects in this trial are Black, keep in mind that one of the exclusion criteria, having chronic kidney disease, has a higher likelihood of being a comorbidity for Black patients in the United States, where most of the study sites are. My main point here is that achieving true inclusivity in research is complicated and multifaceted. Improvement requires constant questioning and critical thinking. This quote is just to remind us to be patient with ourselves and with one another. Remember that social distancing is a privilege. The ability to isolate in a safe home, work remotely with full digital access, and sustain monthly income are components of this privilege, a privilege that many around the world do not have. So let's practice gratitude. In conclusion, race matters. We must be cautious, however, in our use of race as a variable. We must define race well, avoid assumptions that racial and ethnic differences in study outcomes equal biological differences, and not use race as a proxy for socioeconomic status, or vice versa. From the image on the right, you can see that in general, clinical trials are made up of only 5% of Black people and 1% of Latinos. Furthermore, US physicians and NIH-funded physician researchers are mostly white. So many factors contribute to the continued underrepresentation of certain groups in research. Without racial and ethnic data, we cannot monitor progress or setbacks in addressing such inequities in health. Remember that the inclusion of minorities affects more than minority health and health disparities. It is also a question of social justice and of good science. To be thorough and meaningful, our clinical studies must include diverse populations. When you write about a study, consider who is included. Did ethnic and racial minorities participate in the study? If not, why not? If the study population is overwhelmingly white, you should be skeptical. If the researchers found differences between people of different populations, did they consider all of the reasons why such differences can occur, or just jump to a conclusion that it must be because the races are biologically different? By asking these questions, we can help improve clinical research and ultimately help end health disparities. These are my references. Thank you so much.
Thank you very much, Lael, for that beautiful presentation, which brings up very important points that we must consider. We have time for a few questions right now. We're a little bit ahead of time before discussing the emergency use authorization for Remdesivir at UMass, and then some comments by Sarah Forrester about overcoming disparities in clinical trial design. There was a comment by Sylvia Corvera that since comorbidities such as kidney disease are more prevalent in the exact same groups that are more susceptible to COVID-19, should development of new antiviral drugs be focused on those less likely to have nephrotoxicity? And are there any drugs that are better than others in terms of nephrotoxicity?
Is that to me? Or
well,
yeah, Dr. Forrester, please help me out.
Well, I mean, I think that yes, they should, but I am not a MD and I don't do drugs. I'm a social epidemiologist, so I don't know if they exist. I hope if they don't that they can, but it's definitely an issue. What she's saying for sure. But I'm not super knowledgeable as far as drug making goes. So I don't know.
I'm sorry, Dr. Finberg, you were going to comment.
I was just going to say, I think there are many drug trials, and I think we are certainly looking for drugs that can be used. But right now, we just don't have the right drugs yet. I'm hoping that we'll be able to modify drugs to allow them.
There's another question from Jeff Zoe. For international trials like Act 1, are patients and races recruited from international countries comparable to the diaspora in the United States, such as African American versus African? I guess.
Yeah, Dr. Finberg, I don't know about the trial.
No, I don't either. That's a complicated question. As you say, race is a complicated business, and I don't, you know, every country is different, and I can't respond to that.
Another issue in clinical trials is that oftentimes entry criteria require patients to be naive to certain medications that are being studied. And in developed countries, it's hard to find patients such as those. So clinical trials are moving to areas where patients have less access to medications, such as Eastern Europe, and the results from those populations may not be representative of Western populations. In Africa, there's very little availability of biological medications, and clinical trials are not necessarily conducted there. So all of these issues need to be taken into account when considering how clinical trials should be conducted in the future.
Yeah, and to Jeffrey's point, I think that's kind of why I try to have that slide in there and really mention the specific countries from which the people were recruited. And you saw on the slide that 45 of the 60 slides, or 60 plus the 13 subsites, were in the US. And so when we talk about the Black population recruited, I'm assuming that most of them were probably from the US. And when you're mentioning the diaspora, for example, like even if we talk about Africa, it's a continent with many different countries and people themselves are different. You know, so comparable and you know, is one Black population the same as the other? I mean, even when we're looking at the US and we're talking African American versus African, it's very, very different. And then if you keep in mind, like, generation of immigration, for example, like I'm a first generation immigrant to the US, and you know, compared to my parents, like there are differences culturally, mentally, and all of those things really do play a role in, you know, when we talk about even signing up for clinical trials, for example, right? Like I'm the first one in my family to be in medical school, you know, so I am kind of, it's not something that's so scary to me. And you know, but other populations, if you're talking about African Americans, or if you're thinking of you know, the history with science and sometimes, you know, not getting treated correctly. And so there are differences in that, and even signing up and taking part. So I do think that it's very different. You can't really compare one to the other. And that's why I'm trying to, you know, bring to our minds that let's try to keep in mind, you know, to try to reach out to those who we're not seeing, and keep asking, is everyone here? And even of the ones that we're seeing, are they representative of the whole? And oftentimes they're not, which, you know, makes things very complicated indeed.
Thank you very much for that, for putting that so eloquently. This is an incredibly important aspect of clinical trial conduct, and something about which we must pay great attention. I'd like to turn now, since there are no other questions, to the next presentation, which is by Kevin Gao about the emergency use of Remdesivir at UMass.
Thank you, Dr. K. So I'm going to be showing some data that we have about how Remdesivir was distributed in the UMass hospital system. And I just wanted to first start off with a summary of, let's see, there we go. I just want to recall what's been gone over in the last two presentations. So Zach went over how healthcare disparity leads to disproportionate burden of comorbidity in minority patients. And Lyle just now very nicely demonstrated that there's a history of racial bias in clinical research that has limited access and inclusion of minority patients in our understanding of critical therapies. So the goal or question of this presentation is, how are these factors reflected in the emergency use of Remdesivir at UMass? So I just wanted to give a sense of this process through which Remdesivir emergency use is authorized. So in the general population, some fraction will be hospitalized for COVID, and those with severe symptoms will undergo review process for whether they will be allowed to use this new medication. And they are deemed either eligible and ineligible. And at each of these black arrow steps that we see here, bias can be introduced. So we had the fortune of having Dr. Maureen Campion share with us a lot of the statistics, or the demographic data that's been coming out from the hospitalization of COVID-19 patients in the UMass healthcare system. So she's our hospital pharmacist at UMass, and we took this raw demographic data and we did further stratification and statistic analysis to understand potential processes that might have racial bias introduced into them. So our first question was whether hospitalization rate for COVID was related to race or not. So our null hypothesis here is that the hospitalization rate is independent of race, and our alternative hypothesis would be that it is in fact dependent on race. And so what we did was we took the expected hospitalization rate as the proportion of the known racial diversity in Massachusetts, and we compared it to the outcome hospitalized rate. And we found that indeed, when we did a chi-square test for this categorical variable, we saw that there was a statistical significant bias that was first introduced when these patients were hospitalized for COVID-2. Next, when these patients were, whether they were considered for review of EUA or not, our hypothesis to test whether these two factors were related showed that there did not seem to be a statistically significant relationship between the probability of being reviewed for EUA and the race of these patients. Finally, the eligibility for EUA also was not consistent with racial bias, as when we looked at the patients that were ineligible or enrolled for EUA, this also did not come to a statistically significant difference. So we have to accept our null hypothesis here that eligibility or ineligibility for the emergency use authorization is not related to race, at least in the UMass system. Interestingly, when we look further at why these patients that were ineligible for EUA were denied use of this medication, what we found is that there's this trend towards renal and hepatic impairments being seen more commonly in non-white patients, as was discussed by Zach in his presentation. So if you look at this, this red part of the pie chart, you see that there's a lot more renal and liver toxicity concerns in these non-white patients that were ineligible for the emergency use authorization. Although this didn't come to a statistical significance, this trend reflects health disparities that lead to increased comorbidity burden in minority patients. And so to kind of bring to a summary what I've just shown, this data is consistent with health disparities contributing to risk for COVID-19 and access to Remdesivir emergency use at UMass. So these are the steps at which we've kind of identified this racial bias to occur. And the form in which it seems to occur is that racial health disparity leads to this increased burden of comorbidity, which both increases the risk of these patients for infection by COVID-19, as well as increasing their likelihood to have toxicity to Remdesivir, thus denying their emergency use or leading to their emergency use ineligibility. So with that, I'd like to transition over to any questions that you might have, and finally to Dr. Forrester for her summary statements.
Thank you very much, Kevin. There was a comment or question earlier about vaccination and might there be disparities in access to a vaccination once one becomes available for COVID-19, for SARS-CoV-2. And Lael responded that probably there will be issues such as transportation, language barriers, health literacy will make it more difficult for certain populations, racial populations, to receive the vaccination. Lael, would you like to comment?
Yeah, and my question, I was also trying to keep in mind, not just answering for like the US population, but globally, you know, when we're thinking of, like I'm thinking of my family in Peru right now, and you know, how difficult it is for them, even without social distancing and mass access to good care in hospitals, you know? So even without COVID-19, it was already so hard because of limited equipment and you know, not being able to pay and things like that. So, you know, when it comes to vaccination, and inevitably, you know, the first batch is going to be rolled out to certain populations, and those who don't live in the right place, don't have the right amount of money or connections, are most likely not going to be the ones to get it, you know? So I do think that these things, they flow into each other, unfortunately, but, you know, hopefully as a global community of people, we'll get to a place where we can, you know, be more interconnected and more helpful to one another.
Thanks. And the World Health Organization, despite the bureaucracy, contributes significantly to global efforts. And unfortunately, the president just announced that he's withdrawing United States support for the World Health Organization, which is tragic. But moving on, I'd like to now turn this over to Sarah Forrester, who's going to talk about overcoming disparities in clinical trial design.
Okay. Oh, hold on. I didn't hit my button. Okay, can y'all see that? No?
No, we don't see the screen yet.
Sorry, I didn't hit share, my bad.
Oh, we can see it.
Got it? Okay.
Yeah, now.
All right. So hi everybody, I am Sarah Forster. I'm an assistant professor in the Division of Epidemiology in the Department of Population and Quantitative Health Sciences. And I'm going to be talking about overcoming health disparities, both in what we're seeing in COVID-19 and in clinical trial design around possible medications for COVID and beyond. Okay. So this is the outline. I was going to do a recap, but it's kind of already done, so I can probably skip that a little. What we can do regarding COVID-19 and what we can do regarding clinical trials. So for the recap, I was just going to mention what Zach and Lael had already said, but that was already very elegantly done, so I don't need to. So I just want to make a caveat here that all of the stuff that we're talking about is not caused by race. As Lael said, it's not biological race. It's the structural inequities that are faced by minorities, specifically in the US is what I'm talking about, but also in other countries as well. And they result in poorer health and on average, higher exposure. And the disparities that we're seeing in COVID-19 follow the same disparities that we see in many chronic diseases. So it's not necessarily people's habits or their biological race that is the problem in the situation. All right, so starting here. So, so some of the, have pictures here of some of the strategies that can be used to mitigate COVID-19 or the disparity in COVID-19. So obviously, you know, experts have been saying for months and months and months that we need ramped up testing and contact tracing. And that is important for the whole country, of course, and for all the areas of the country, but it's especially important in economically deprived areas, in areas that are mainly occupied by minorities in the US. And when I say testing in these areas, I don't mean tell them, you know, they need to get testing or campaigns to tell them to get testing. I mean, actually have testing within these neighborhoods. And there are some states that are doing that, or they're trying to do that now, to target testing and put them in those areas. But the best way to do that is to partner with community leaders, churches, historically Black colleges and universities, and have the actual testing sites within those places in these neighborhoods and in these communities. And have the contact tracers be people from the community, because a lot of minority communities, so African-American communities, as well as communities that have undocumented peoples, they're going to be afraid of people who they see as in authority, or people who they think are doctors, or people who they think are from the government or whatever. They're not going to want to talk to them. They're not going to want to answer their phone. Excuse me. I know there was one place where they make the numbers from the contact tracing. They use like a ghost, whatever you do to change the numbers of where things are coming from, so that it matches the clinic that's in that neighborhood that everybody knows the phone number for, so that they'll answer the phone and talk to the contact tracers, because they know otherwise they're not likely to be able to get in contact with people, because they don't want to talk to people outside their neighborhood or people they don't trust. So in addition to that, using these community leaders and church leaders to kind of spread appropriate information about the virus. So dispel with misinformation, spread appropriate information like safe practices to avoid contracting it, what to do if you feel like you have symptoms, what the symptoms are, and where you can go to get testing. There's also distributing the essentials within economically deprived neighborhoods, like masks, soap and water, hand sanitizer, and food, And again, this is being done in some places, not so much in others. But it's, it's difficult for people to wash their hands if they don't have running water, or they don't have Purell if they don't have running water, or they don't have soap. And this is obviously something that we're also seeing within the not Native American, I was thinking about something else, within the homeless population. So in the middle there, as being an epidemiologist, in all caps, is my data. Collecting data is, it seems like it's not doing much at the present time, but it is actually rather important, because understanding the racial and ethnic breakdown within the US and the geographical information to determine the hotspots and why there are hotspots. So what is the, what are the social determinants of health looking like in those areas? Are they not near testing? Are they near underfunded hospitals or clinics? So what's happening is a way to rapidly deploy resources when they're necessary. And in that vein, just yesterday, Google announced that they have awarded a $1 million grant to the Satcher Health Leadership Institute at the Morehouse School of Medicine to look at the racial impact of COVID-19 and address racial disparities. So they're going to be creating a real-time COVID-19 collection on racial and ethnic disparities, and actually had a database that has a detailed breakdown of the virus's impact by race, ethnicity, gender, and different social determinants of health, to help policymakers understand where they need to be putting the resources and support to stop the spread and lower this disparity that we're seeing. So another way that's to help with this issue is examining our own biases. So we know that in general, as a general population, we all have unconscious or implicit biases. But the research has shown that physicians also have these biases, and that they actually affect the way that they care for their patients. So it affects who they send for testing, who they ask to join clinical trials, who they give medication to, who they believe about their pain, things like that. And these biases are enhanced when there's overcrowding and when there's a high patient volume, which is what we would expect during a pandemic. So that makes it doubly important that we understand our unconscious biases toward, certain groups, racial groups, sexual and gender minorities, weight stigma, age stigma, gender stigma. I mean, there's a lot of them, but as what we're particularly talking about here is race implicit bias issues. So understanding that now is important in general health, as well as for if we have a second wave, and for the places that are still, dealing really hard with the first wave. And as we're starting to reopen, we may be seeing more hospitalizations and more people coming in, and that makes this extra important right now. So now I'm going to talk something about clinical trials. So we heard in the other talks that the people who were excluded, some of the people who were excluded that were minorities were excluded due to renal disease. And that is, for that medication, it may not necessarily be fixable. I'm going to talk about a possible way to fix it, but I don't know if it would work for that medication. At the very least, I feel like this could be useful for other trials and or possible medications that could come out in the future for COVID-19 and for the vaccination for COVID-19 when it happens. So we all know explanatory RCTs. There's the RCTs we hear about mostly. So on the other end of that continuum is explanatory RCTs. Or excuse me, pragmatic trials. Sorry about that. So these are especially relevant in this situation because they include real world situations such as people with certain comorbidities, people who have co-medication, and non-adherence to medications or even to protocols. So pragmatism in this case is measured by the study population, the trial setting, the operationalization of the intervention, and the outcome measures. So as you can see, it's a continuum. So there can be some RCTs that are more pragmatic than others, but a fully pragmatic trial would enroll people rather than using strict exclusion criteria, would enroll people that from a target population that you would actually see in the clinic. So people who are representative of the heterogeneity that you would see within these subgroups. So people with renal failure, people with high blood pressure, diabetes, multiple comorbidities, non-adherence, all of these. The trial setting in the most pragmatic way would be within a routine care setting. So within clinic or within an emergency room, whatever it is that you're testing, rather than the specialized RCT setting where, you know, you go into the study and you get your study meds, you meet with your person and you leave. This is more so during actual care. And then the operationalization of the intervention. So again, when you have an RCT and you have people that have these issues, you tend to just stratify by them, or make sure that there's the same number of people in the treatment and the outcome, or excuse me, the treatment and the control group who have the same thing. Whereas in a pragmatic trial, you would kind of model these situations, so these comorbidities, because that's really what you're going to be dealing with in clinic when you're giving this medication in the real world. And then finally, outcome measures. So rather than looking at how biologically meaningful it is, you're looking at how clinically relevant it is. So yeah, this medication worked really well in an RCT for, you know, this very highly specialized population, but when we get it into the clinic, there's so many side effects that people stop taking it, or, you know, whatever other issues may pop up. So these trials, they are still randomized, and they are actually more relevant to real world populations, and they're a more realistic reflection of the likely treatment effects. They're not all perfect and not all like rosy and great, because they can be harder to run. There's more dropout because it can interrupt the usual care. The goal is to not have it interrupted, but that doesn't always happen. And they're usually conducted after safety and efficacy has been established in a phase 2 and a phase 3 trial. So it's not necessarily always either or, but they can also be used in the absence of those trials when there's an acute unmet need. So if there's like a disease ravaging the country, you know, like now, they can be used to look at populations that might be having specific issues with whatever is ravaging the country at the time. So in conclusion, talking about these issues, structural inequalities, our own biases is difficult. Nobody likes it. Nobody really likes taking a deep look at themselves to see what they think about other people, and you know, thinking about the fact that other people, how they're living and what's going on with them as opposed to how you're living. I mean, it's very uncomfortable, and we can see it now with what's happening in Minneapolis, that it's painful to watch and it's hard to watch, and it hurts. But these types of conversations and things are necessary so that we can actually take a proactive interdisciplinary approach to understand how we ourselves perpetuate health disparities and how we as a system perpetuate health disparities, so that we can identify strategies that can help and opportunities for future improvement in ourselves and in our system. And these are mainly short-term things that I'm talking about here, but in the long term at the local, state, and government, federal level, to help ameliorate these health disparities. And this is, again, just a very brief overview of all the ways to help ameliorate health disparities, but it's just a start. So here are my references, and I am done.
Great. Thank you very much, Sarah, for that discussion and explanation of clinical trial designs. I'd like to acknowledge, I see Rob Phillips has joined us. Rob was the director of the Heart and Vascular Center of Excellence at UMass Medical School before he left to become Executive Vice President and Chief Physician Executive at Houston Methodist. So welcome back to UMass, Rob. It's good to see you. Bruce Barton is attending, and Bruce, if I could take the initiative to ask you to comment on trial design, how might a pragmatic trial be applied to the development of antiviral therapy for COVID-19, and might there be some role for adaptive trial design to include patients in a later phase who might have been excluded in the initial phase?
Well, boiling a 5-hour response down to about 30 seconds. But I'd like to actually bring up something first, which will give me about 30 more seconds to think about an answer. But in trial design, when I design a trial, I always design it so that I can look at subgroups. And, NIH is very focused on studying females and not just males. They should also be just as focused on studying minority groups. However you want to define that, and NIH has taken a stand in terms of what constitutes male and female. That's fine, whatever they can do. But I think we need to design studies and fund studies. That's the critical element. Fund studies with enough patients to study subgroups. I mean, you can include, a few more African Americans or Africans or Hispanics, but if you don't have enough sample size, and I hate to put it this way, but if you don't have the sample size, you'll never get to the answers. But sample size is expensive. If I need 1,000 patients rather than 500 so I can look at subgroups, it's going to be twice as expensive. And so we have to understand that as a society, that if we're going to study, what we're talking about here today, we have to have the funding behind it. And 500,000, which used to be a lot of money, is now, you can go through that like water. We need a much higher limit on, maybe even double. I don't know. I mean, I haven't thought through the economics of it, but it needs to be a much higher support limit for even the big R01s or the UO1s that we're doing today, so that we can look at subgroups. You try to do it, you write the analysis plan to do it, and then you come up with 13 African Americans. Well, how am I going to study 13 African Americans divided between two groups? I don't know.
As Lael and Zach and Sarah pointed out, we also need to reach out to these communities and educate them about clinical trials to dispel some of the misconceptions about clinical trials and encourage enrollment of individuals from these populations in clinical trials.
Right, exactly. So to go back to your original question about pragmatic trials, I'm a big proponent of pragmatic trials because they're, pragmatic. They look at what actually works as opposed to what could work. So you run a clinical trial, and you're absolutely right. The people who have given presentations are absolutely right. In a randomized clinical trial, you're looking at patients you're selecting patients who you expect to have the best response. Because if you don't get a response in those patients, nothing else matters, right? So, well, that's fine. So you randomize patients, and so people with kidney disease get randomized to the two studies. And so that's fine. But you're only answering part of the question. You're answering, can it produce a response? The real issue is, does it produce a response in the real world, because of all the issues that people have brought up? If the side effects are disruptive, if people can't take 12 pills a day, if there's a bunch of other factors that people have brought up. If you can't, you don't really usually study those in a randomized clinical trial, but you can in a pragmatic clinical trial, because they're usually much larger. Pragmatic trials run, several times larger than the standard randomized clinical trial for the FDA. And so, so pragmatic trials can really answer questions that a randomized trial cannot. Now, the question that you brought up, John, is can you do an adaptive design as you're moving forward into a pragmatic trial? The answer is sure. I mean, there's a lot of designs out there now that we can tap into, and we really need to start paying attention to how, the era of the static clinical trial is probably over. I haven't designed a static, a sample size of 200, that's it, no questions asked. I haven't designed one of those in probably 5 years, maybe even longer. Virtually every trial I design now has interim, adaptive design as part of it, because you have to go with the flow. You have to see what you're learning from your current trial and how can you take that forward to better answer the question. Okay, this is not an ego trip. This is about patience. And I think that's where we lose sight. We have to treat patients. And, it doesn't really matter whether it's male or female, black, white, Hispanic, a Pacific Islander. It doesn't matter. Every patient is an individual. And so, I totally, I understand exactly where people are coming from. We have to really start changing, the environment of research so that we get more researchers from minority groups involved. That's going to be, a major step forward, because they're the people, the individual investigators are the people who are driving the research. So
thanks, Bruce.
Yep.
Arlene Ash is also in attendance. Do you have comments about trial design or how one might incorporate more underrepresented racial groups into clinical trials? There, I think you're unmuted. Great, thanks.
So this is multi-pronged. You have to not just teach people that they ought to come to trials, but really engage them in research. And groups that have historically been excluded or just not included in trials, that they participate in designing and understanding, in contributing to our understanding of what research would be most useful to them. So I think that we are learning a great deal more humility, that this kind of environment in which a bunch of us with very different backgrounds and all involved in one way or another in a research enterprise, that we are learning some of the complexity. As a mathematician, when I analyze a study, they're just numbers, but we see these 3 examples of people with astonishing complexity in their medical histories and their social histories and everything else. So I will say, out of the chaos of the current situation, I am delighted to see this coming together of people across the medical school to use our mutually reinforcing expertise to start to do science that's more meaningful.
Thanks. As the end of this session comes near, I'd like to just take the prerogative to sum it up. We first heard Ted Carrigan-Broda give an overview of the pharmacology of remdesivir, a lipophilic molecule that interferes with the RNA processing of the virus and is renally excreted, so that individuals who have compromised renal function may not be able to receive that drug as easily or at all compared to those with normal renal function. We then heard Bob Finberg talk about the very successful clinical trial that was conducted very rapidly, and UMass was involved in a major way in this trial, which demonstrated the superiority of remdesivir to placebo and has led to this next trial, which he's conducting with colleagues at UMass to look at baricitinib in combination with remdesivir, now included as standard of care. We heard the presentation of these 3 cases, very difficult patients, each of whom might have benefited in some way from Remdesivir, but only one of which was able to receive Remdesivir as part of the emergency use authorization of the very short supply that was provided to UMass Medical Center. We then heard Zach Dyer talk about the disproportionate effect of COVID-19 on minority populations and a number of the demographic features and social aspects that contribute to the increased impact of a devastating disease such as COVID-19 on those populations, the workforce, the jobs that those individuals are carrying out on a daily basis, the crowded housing situation, use of public transportation, and so on. Lael Gangmani then gave a very eloquent presentation about the racial disparities in clinical trials, introducing us to a number of the different factors that are operative when clinical trials are conducted and proposing some issues that need to be addressed in the future. We then heard an interesting analysis by Kevin Gao of the emergency use of Remdesivir at UMass and how different populations were affected by this. And finally, Sarah Forrester talked about different ways to overcome disparities in clinical trial design, ways to educate minority populations about clinical trials, to embrace them and to engage them in clinical trials, also proposing the use of pragmatic clinical trials as an alternative to the traditional randomized controlled trial, which has very strict inclusion criteria and many exclusion criteria. So with this multidisciplinary virtual clinical research forum, we've covered from the basic science, from the pharmacology to the clinical trials to the social issues related to clinical trials. And this illustrates the tremendous range of talent, collegiality, and collaboration that we have here at UMass Medical School and UMass Memorial Healthcare. And I'd like to take this opportunity on behalf of my colleagues, my co-organizers, co-presenters, to thank all of you for spending these 2 hours with us. And I look forward to your joining us for more virtual research fora and eventually in-person research fora once we're able to get together in a more unified, personal way. Thank you very much for your attendance, and I look forward to seeing everyone in person.